Welcome to Keiser Voices, the story of success, brought to you by Keiser University Graduate School, here where the academic world meets personal triumph. Join us today as we dive into the captivating tales of success.
Hi, everybody, and welcome back to another fantastic conversation that we're having this month and all month here on the Voices of Keiser podcast. And May is really important. We really need to have some of those tougher conversations because May is Mental Health Awareness Month. So this month, we are bringing in the experts to talk about mental health, what it looks like, and what it means to us. So please make sure that as you guys listen to these podcasts, that you're checking out the descriptions. We are going to have some tough conversations, and it could be tough for you to listen to. So please make sure that you listen carefully, and you also check out the description of the podcast. With us today to start these conversation is Dr. Tina Glover. Joins us from our clinical mental health program here at the graduate school. She is in charge of the program as well as a faculty member, but she comes with years of experience in counseling. One of her specialties, which is what we are talking about today, is addiction. So Dr. Glover, can you tell us a little bit about your background before we start talking about the topic?
So I have been in the addictions and mental health field for over 2 decades. And so I started off in addictions counseling and working with individuals who had both physical and psychological addiction to substance use, gambling, sex, those things. And so as such, I am a state and nationally certified addictions counselor level 2, which means I can supervise other addictions counselors who are new to the field. And I'm also a licensed professional counselor in multiple states as well. So that's kind of where my background comes from.
No, and we appreciate you taking the time to have this conversation with us today. So addiction.
Thank you.
What's addiction? Like, what's the proper definition of addiction that we're looking at when we say somebody, is diagnosed with addiction issues?
Mm-hmm. Okay. So it depends on who you're asking. And so in the DSM, which is the Diagnostic Statistics Manual that we use in the field, we're looking at a psychological, physical characteristics that someone has to a substance or an activity. So it's this persistent, ongoing urge to seek that drug, that substance, or that particular activity, right? And then there's this medical model where some people will just say that it's the physiological things that go on with somebody, and then they can kind of stop. So some people have a misconception that it's not a psychological thing, but over time, your body does, gravitate to this psychological change that causes that addiction.
Okay, that actually clarifies a lot for me, because I think I kind of had my own definition of addiction, and apparently it was not the proper. So there's a lot of misconceptions when we talk mental health. There's a lot of misconceptions when we talk specifically addictions like we are today. In your experience, how do those misconceptions affect those that are already dealing with these struggles, with these, addiction problems or concerns that they're facing?
So when we talk about misconceptions, I guess you have to look at it on multiple levels, right? So if you look at it as the individual may feel as if this is something that I'm doing, I'm passing time, it's not hurting me, it's not hurting anyone else. They may not realize the psychological effect that's happening. They more than likely don't even realize the physiological effects that it has. And so when you engage in something on a repetitive basis, like let's say marijuana, most people think marijuana is okay. And we have a lot of states now that recreational marijuana is okay, right? What people don't realize is that you have this dopamine receptor in the back of your head. And I tell people, that's your feel-good receptor. So you smoke weed, I feel good, right? And so then they continuously do that. Well, you're changing the chemistry of your body. You're changing the neurons in your brain. And so it's not as easy to stop as some people may think, right? So that misconception that they can stop. Family, friends, society, they also have that same misconception. So those misconceptions happen on multiple levels, but some people, it's just like, it can't be addictive. It's harmless. I've heard people say things like marijuana is natural. It's not like I'm using heroin, right? And my response is heroin is natural too. It came from a plant as well, right? Cocaine came from a plant as well. They all may have started off natural, but by the time you finish with that process to it, and sometimes other chemicals added to it, it's changing your body chemistry. It's changing your mind chemistry. And I think that's the biggest misconception on a personal level, familial, friends, and society, that people can just stop.
So then obviously admitting is that you have an issue is the first step. But are there other barriers that we're seeing people hit that are struggling or that they need to overcome to be able to start getting help?
I think the biggest barrier is money, the lack of healthcare, the lack of funding. A lot of times what we find is when funding gets cut, the first thing that gets cut in funding is mental health and substance abuse treatment. It seems to always be the part where people can take this fine line away from it. And then what that does is when a person has instability, so let's say we call it polysubstance use. So I started off with drinking, and then I might have started smoking marijuana. And then somewhere along the line, maybe my friend introduced me to methamphetamines, right? That lifestyle to continue to get my drug has now left me with no job and has left me with stability as far as housing is concerned, right? So for that person, an intensive treatment may be needed, putting that person in a residential facility. If you don't have family or friends with the money to pay for it, if you don't have insurance to pay for it, then what we're hoping for is those county beds or those city beds that are paid from this grants and these funding. So when you take away that funding, you take away those beds. And so then that person is just left to their own accord outside. And oftentimes what I find is when I'm working with somebody in an outpatient setting, when a bed finally comes up, they're poof gone because now they've gotten back into that rat trap of hustling to make more money so they can seek those drugs again. And it progressively gets worse depending on the drug of choice for that person, or affliction, not necessarily the drug, their affliction of choice, because some people it can be drugs and gambling or gambling and sex. That's addictive for them.
We understand like a lot of those that are struggling with addiction, they can't even admit that they're struggling with addiction. They think, as you said, like they can just stop. Like it's not that big of a deal. If I wanted to stop, I can.
Mm-hmm.
But we also know that there are barriers to it. And we know like historically, we don't like to talk about mental health, mental illness. How, I guess, do we either provide a supportive environment or how do we get these individuals to even take that first step and say, you know what, hey, I need help?
Mm-hmm. So when it comes to addiction, what I find is that a majority of my clients are mandated. And when I say mandated, most times people think they've gone to jail, they've gone to court, probation, through that whole process, and then they come to us. But mandating doesn't necessarily have to be a legal thing. Mandating can be also a familial thing as well. So my partner has a gambling problem and it's you either go get help or I'm gone type of thing. So a lot of times it's very difficult, like you said, for people to admit that they have a problem until they have gotten in some type of trouble or they've hit their bottom. And when I say hit bottom, my bottom is going to look different than your bottom. right? And so there's never two alike. It can be the bottom is, I'm homeless now, I've lost my, and I'm sofa surfing. Well, now I have nowhere else to go because no one wants me to sofa surf. And so now I'm living on the streets. I need to get help. And so now let me go get help. So those are some of the rare ones sometimes. And I do say sometimes because I think it kind of cycles through, the month, the year, in the season of when you have more of one versus the other. Like I always tell people during the summer in residential treatment, we have a lot of beds. But when it gets cold outside, everybody wants treatment. It's kind of like that old saying, three hots in a cot type of deal. They know they can come into treatment and they do it. And so hitting their bottom looks different for everybody. And how they admit that they need help is also going to look different for everyone. I believe that support is a good thing, not just the support for the person who has an addiction, but then there's support for the family and the friends, those significant others of the person who is struggling with an addiction. So finding that help and accessing that help to me is key.
So that makes a lot of sense. And I think too, and again, I have minimal training on the topic, but I know people that do suffer from mental health concerns. I think the way that we talk and even look at mental health has evolved over the last decade. Even in the last decade, there were periods of time where people would lock away somebody with a mental disorder, not just addictions, but as a society, they were shunned. And I would like to think that we've come a long way. But is that true? Like, have we truly evolved at how we look at mental health and even our understanding addiction? Has that evolved? Has that changed?
Most definitely. Many don't know. I'm what I call an undercover nerd. So I love documentaries. I love looking at history, especially when it comes to mental health. And we would never say that that person had a mental health issue. We would say that person was feeble. They needed to go to a school. Right? We had these schools for people, and they were specially designed for people who had some type of challenges. Our schools today is our outpatient and our residential treatment facilities that people have. So the quality of care people get is a lot better than it was in the 1800s, the early 1900s, and even now, that we're in 2024, we are now. So we're definitely 20 years ago, care that people receive is a lot better. We invest a lot in evidence-based practices, right? So we know what works. We know that if a person is dealing with some type of addiction, cognitive behavioral therapy works for them. And in layman's, I tell people cognitive behavioral therapy is looking at the thinking behind the thinking. Why do I do these particular things? We know that motivational interviewing helps, which is really looking at a person's strengths and their weaknesses and really trying to get that person out of that negative thought process into a thought process of change and getting there. And those two together are awesome therapies if you use CBT and motivational interviewing, MI, together. So those are awesome to help and change. I think that we still have a long way to go, but we definitely have come a long way. Because I even think back, just random thought just hit me, is even thinking back to the 70s and the 80s when addictions counseling was done by addicts who had no formal training. They were clean and sober for a couple years, and now they're running these different, facilities. And that's nothing, to shun about, because if we think about AA, the founders of AA, they would open their homes to other addicts or alcoholics and let them, dry out and try to help them through that process. So that there's a long background of people who are suffering from addiction, who's recovered from their addiction, providing care to help other addicts find change. Today is that we still have those same people. We have a lot more educated individuals who what we call normies, who cannot identify with a substance abuse addiction. But what I try to tell my students is that we all have an affliction. We all have some type of addiction. Yours might be soda pop. Somebody else's might be chocolate. I tell people mine is shopping, and I relapse daily. It's like gotta go grocery shopping. Is that, how is my body and my brain chemistry wiring when I go grocery shopping if shopping is my affliction, right? It's the same with someone who says that they have a sex addiction. If you're married, you're still wanting to be intimate with your partner. So how do you deal with that? So we've come a long way with evidence-based practices. We've come a long way with our thought processes. We've come a long way in the sense that we have more normies providing counseling and care to people with addictive behaviors. And we've come a long way where we're recognizing things like our mini computers. We're on cell phones all day. This is a mini computer, and this mini computer is addictive. And we are now looking at how do these tablets and phones, how are they changing the brain chemistry of our teenagers? So there was a time where we were like, this is your brain on drugs and crack the egg in the skillet, and you've seen that. Well, this is your brain on an iPhone now, or this is your brain on an Android after so long. You're not getting sleep because you're too busy scrolling on Instagram and, Facebook or whatever it is that they're doing on social media. So there's definitely more room to grow.
And I mean, that makes sense. Like things change and how we look at it, different tools become available to us. And I know you mentioned a couple of therapies and studies that are currently being used to take a look at addiction and understanding addiction. Are there any other successful strategies or therapies that are very effective when it does come to addiction?
I think there's a lot. So I am an integrative therapist. And so what integrative therapist basically means is that I use multiple therapies when working with people. I will develop the Heather model if I'm working with Heather, right? So I might use some narrative therapy to rewrite your story. So if my substance use or my gambling or whatever my addictive behavior started to cope with some type of traumas in my life, I might use narrative therapy to rewrite that story. Definitely, I definitely lean on MI and cognitive behavioral therapy, but some people use solution focused therapy, which is a very short time based type of therapy. Person centered therapy. It's about that person and where they're at, and MI borrows from that. Specific models that are out there. There's an old model, but I like oldies but goodies, which are like the Matrix model. And I really love the Matrix model. SAMHSA did this whole study on it, provides a manual for the facilitator on how to facilitate groups to help this person. And the Matrix model came out when methamphetamine use first blew up. Right. So it's an oldie, it's a goodie. I love it. It really helps with relapse prevention. So there's tons of ways that you can look at this. And I say tons because it's a mixture of different therapies if you're an integrative therapist like myself.
Okay. I don't want to take up too much more of your time because I know between your students and your clients, you're definitely very busy, and we're so grateful to have you. But I do have one last question, if you don't mind. So it is Mental Health Month. We're spending the whole month talking to professionals, bringing light, hopefully providing support or maybe even some insights and hoping that we're getting rid of some of the misconceptions. But are there Are there ways, or what can we do as a community to do better to support the individuals and families impacted by addiction?
Um, be open-minded. I think that people shun people who are struggling with some form of addiction. Um, there are some addictions that people will embrace, but others that people are shunned. So be open-minded. Sometimes it just takes one person in one caring situation to help someone. And you may not know what to do. So an example of that is that I was a new therapist, a new addictions counselor, and I kept hitting the wall, not knowing what to do with a client of mine. And I just said, hey, I don't know what to do anymore. Every time I turn around, that we're relapsing, we're having all these other issues. And the person left treatment. And a year later, I got a letter from them saying, thank you. It was the first time somebody was just ever very direct with me, but patient with me, because I tried to be as patient as I possibly could. He admitted he did relapse, but he had been clean for a year when he had sent that letter. And so that to me felt good. And so I've always said, you can have tough love, but it's how you deliver tough love as family members, and as friends. It's being open, being able to say, I don't know it all. And if you're struggling, being a support system, going to groups like Al-Anon or Nar-Anon are really good support groups, because you can work and heal on you. If you're a professional, I think the things that you can do is advocacy, going to our state legislatures. I can't, now I'm tongue tied. I think I've borrowed a little bit of somebody else's stuff. But going to your state capitol, going to, your city hall, and being able to go to different town hall meetings and things of that nature in your community, and advocate for services, advocate for those monies that disappear because they need to level out a budget line. Those things are very important. And I mean the work. I've seen it in different cities and in different states where when people come together, band together, and fight for those funds, they're there. And I've seen when people are less knowledgeable and those funds are taken away. And an example of that is I worked in a outpatient setting, and working in that outpatient, there was another facility a couple blocks away from us. And one morning we came in and did our morning huddle, and my supervisor at that time let us know that I'll say it is Unity, is what we called it, but it had a whole long other name. But Unity had shut down. So 100 and some odd employees now lost their job, and thousands of people who needed care no longer got care. Unity provided free care to people with not just mental health issues, but addiction. Cutting those budget lines is so detrimental to individuals who are struggling and need our assistance. And just in a matter of one election, within, I think, a week of that election in that vote passing, we lost a valuable resource for our community. So knowledge, patience, being open-minded, and advocacy, I think those would be the things that I would recommend.
Yeah, no, I think that those are great points. Having that open conversation and being open to hearing that, and then doing the support, doing the work. I think I'm a big fan of NAMI. I've done a lot to support NAMI. NAMI is a National Alliance for Mental Illness. They're a fabulous organization. They provide a lot of free resources to the communities that they're located in. And my favorite thing that they say and they promote when they come to start talking about mental illness is, you're not alone. And that, I think, summarizes everything so perfectly. You're not alone on this journey. And I think professionals like you go a long way in showing that to the community and to the individuals and your students. So thank you, Dr. Glover, for joining us. Thank you for having this tough conversation, but important conversation. And I hope all of you take something away from our conversation with Dr. Glover and the rest of the professionals we have this month, as we take a look at mental health awareness. So thank you all for joining us. And again, thank you, Dr. Glover.
Thank you. I appreciate it.
Thank you for journeying with us today on Keiser Voices, the story of success. As we close this chapter, remember every story has its next page.